Welcome to the ERA Journal Club. Each ERA e-seminar takes place on the last Thursday of the month at 1700 Central European Time, which is 1600 time here in Oxford in the UK. Each e-seminar has picked out a topic from a recent original research or key review article, and the author or authors introduce their work. There's at least one expert on our panel, and today it will be moderated by our brand new CKJ Editor-in-Chief, Maria Soler. And it will be moderated again by myself. I'm an Oxford-based nephrologist and epidemiologist. Our discussions will last for up to an hour. They'll be fairly informal, and we encourage live and I hope lively questions from you, the listeners, typed into the Zoom Q&A box, and we'll try and address as many of them as possible. It is recorded and will be made available on video platforms afterwards. So keep an eye on social media for links. We're honoured today to have the full trinity of leading European hypertensive specialists who are key supporters of the ERA in many different roles. They are discussing the topic of blood pressure measurement in transplant recipients today, and we have Professor Carmine Zoccali presenting. He is based at the CNR Institute of Clinical Physiology in Reggio Calabria in Italy, and of course is a former editor-in-chief of NDT and the paper's senior author. The paper is entitled Assessment of Hypertension in Kidney Transplantation by Ambulatory Blood Pressure Monitoring, a Systematic Review and Meta-Analysis. And Professor Francesca Mallamaci, well known to many of you as a fellow of the ERA and also an NDT editor. She's the editor for the hypertension topic and is head of hypertension unit at the CNR Institute as well. She was a co-author. So welcome both.
I'm proud to say that Francesca has accepted to be Associate Editor of CKJ this year.
Yes,
Fabulous.
Thank you, Maria.
Thank you for accepting my invitation.
Thank you.
And we're also very grateful to Professor Mehmet Kanbay for joining us as an expert panelist. He is a professor of medicine and head nephrology in Istanbul, and he is CKJ's hypertension section editor and also a distinguished ERA fellow. Notably, he was the senior author of an editorial comment on this meta-analysis. So thank you all for joining and sharing your knowledge today. And we really do have the world experts on this topic available for you live to present. So please take full advantage and use that Q&A box on the Zoom platform. Don't be shy. So without further ado, Professor Zoccali, maybe you could share your screen and give us your presentation of the paper.
Today, I will comment on a meta-analysis that was published recently in the CKJ. And as emphasized by Professor Herrington, this meta-analysis adds new data to the knowledge that was used to build the CRIGO guidelines on blood pressure. We know this is out of context that renal transplantation is the best treatment we have for end-stage renal disease. But renal transplantation leaves many clinical issues unresolved, and one of these is cardiovascular risk. This is a paper 20 years old, but it tells you the whole story. If you stratify the general population by age, you see that the risk of cardiovascular event goes from almost zero in the young to almost 30% in people who reach the 7th decade of life. This line, which is almost linear, is shift upward in kidney transplant patients. And the risk differential is huge, is 2.3 times higher. Put in another way, 230% higher, a huge risk excess. And of course, we are aware that these risks depend on the fact that CKD transplant patients are always CKD patients because their renal function is not normal, and they always use immunosuppressive drugs, and some of them, like calcineurin inhibitors, raise blood pressure and have toxic effect on the cardiovascular risk. And also because with transplantation, there is a resurgence of traditional risk factors, hypertension, hyperlipidemia, but among these risk factors, hypertension is undoubtedly the leading risk factor. In an analysis made by Kasiske, again, this is an old paper, 20 years old, of the risk for graft failure and death, by using office blood pressure. Kasiske and co-workers noted that the risk of graft failure was by the 10% higher per 10 millimeters increase in systolic blood pressure. And the risk for graft failure was 15% higher. And the risk of death even higher, approaching the 20% excess risk. What about blood pressure measurement? How should it be measured? Because the paper that I showed was based on standard office blood pressure. The TIGO guidelines recommend measuring blood pressure by an automatic sphygmomanometer in a quiet room without taking coffee or smoking, which is something which is different from the standard clinical setting in the clinic. And this is undoubtedly a step forward toward more precise and accurate blood pressure estimates. But let's move to the ideal measurement of blood pressure. As you know, blood pressure follows a circadian pattern. During the evening and the night hours, it goes down. And this is so-called physiological dipping. In some individuals, there is no dipping. And the lack of nocturnal dipping causes, of course, an increase in average 24-hour ambulatory blood pressure. This is the average systolic blood pressure of a dipper, and this is the average systolic blood pressure of a non-dipper. We usually measure blood pressure in the office in the morning hour, and it comes as no surprise that if we make this measurement in dippers and non-dippers, we can find no difference between a dipper and a non-dipper. But these elements may conduce to frequent hypertension misclassification, because non-dipping raises blood pressure in the 24 hours, and therefore can mask hypertension when blood pressure is measured in the office. These problems were captured in the guidance given by NICE, and NICE recommends for the general population that blood pressure diagnosis should be based on 24-hour ambulatory monitoring, not on office blood pressure. Now, we all know that there is sparse evidence that non-dipping, white coat, and masked hypertension are much frequent among transplant patients. Thus, we have a question: why not applying 24-hour ambulatory blood pressure for the diagnosis of hypertension also in transplant patients? And this is a problem that remained unfocused in the CTIGO guidelines. Office systolic blood pressure does not capture the blood pressure dependent arterial damage. In this study, as you can see, there was no relationship between intima media thickness and office systolic blood pressure, while average 24-hour systolic blood pressure captures the burden of the effect of burden of systolic pressure on intima media thickness. There is a direct relationship between the two parameters. And office blood pressure also fails to capture the risk of renal function loss in transplant patients. As you can see, office blood pressure does not indicate any risk excess for graft loss, while all metrics derived from 24-hour ambulatory monitoring register a 10% risk excess for renal function loss. And another added problem is that office blood pressure gives wrong indication to guide treatment. In this study, which analyzed over 200 visits in transplant patients, in the 25% of visits, office blood pressure indicated the need of antihypertensive therapy institutional modification, while synchronous 24-hour ambulatory blood pressure was actually normal, so wrong indication. And conversely, in 12% of visits, 24-hour ambulatory pressure was in the hypertensive range, while office blood pressure was in the normotensive range. Collectively, in 37% of cases, office blood pressure gave wrong indication for blood pressure management in clinical practice. Now, until now, I illustrated the problem based on sparse information in personal studies. And I think that we all agree that we need a systematic review and meta-analysis to correctly summarize our knowledge on this issue. And a group of investigators of EURECAM that acted independently because there was no formal endorsement of the ERA Council, and the European Kidney Research Group of the European Society of Hypertension, who had the endorsement of their society, conducted a systematic review that was published recently in the CKJ. Now, the selection of paper. We started with over 900 citations, but eventually selected 51 articles. Now, let's show the pooled prevalence of hypertension when this was assessed by ambulatory monitoring. The criteria of definition of hypertension varied over time. A group of studies were done in the first decade of the millennium and applied old definition. In 2013, new definitions were produced, and in other studies, the threshold were not stated or adopted non-guidelines recommended threshold. As you can see, the prevalence of hypertension varied among these studies. It was heterogeneous, highly heterogeneous. This was true for the studies done during the first decade of the millennium, but also in subsequent studies. Overall, the heterogeneity was very high. High variability in the estimate of hypertension prevalence in the various studies. But the actual pooled estimate of the prevalence was very similar across these studies. And globally, the prevalence of hypertension in these BPM-based studies was 56%. This is the prevalence of hypertension in studies based on office blood pressure. Again, high heterogeneity among studies, but the pooled prevalence here was lower than that we have seen with 24-hour ambulatory monitoring, 47%. That is about 10% less. In other words, the estimate of the prevalence of hypertension in transplant patients is underestimated by office blood pressure. Now let's look at the proportion dippers and non-dippers. More than half of the transplant population of these studies was composed by non-dippers, that is the high-risk individuals. And the proportion of non-dippers declined over time according to the vintage of the transplant patients. Early transplantation for 7 months, about 1 year and more than 1 year. During the first months after transplantation, non-dipping was 73%. It went down to 50% after about 1 year, and the prevalence was even lower, 27% in those who were studied 1 year after transplantation. Let's see now the prevalence of masked and white coat hypertension. The prevalence of masked hypertension was 25%, and that of white coat hypertension, 10%. So I think that we may agree that the possibility of misclassification by office blood pressure in transplant patients is substantial. And when we look at the study that investigated the agreement between office and 24-hour ambulatory blood pressure for the diagnosis of hypertension, we found that 66%, in 66%, the two methods agreed in the diagnosis of hypertension. But in the 34% of cases, they disagreed. So office blood pressure misclassified hypertension in transplant patients in 34% of cases. I think that I can summarize. In this meta-analysis, the comparison of office blood pressure versus ambulatory pressure disclosed a high proportion of masked hypertension, uncontrolled hypertension, and to a lesser extent, white coat hypertension. This result suggests that hypertension is not adequately diagnosed and controlled by office blood pressure in this population. Finally, the high prevalence of non-dippers confirmed that circadian rhythm is commonly disturbed in this population. And my provisional pragmatic recommendation is that wherever and whenever possible, please use ambulatory monitoring for the diagnosis, I insist, for the diagnosis of hypertension in kidney transplant patients. Thank you for your attention.
Thank you, Professor Zoccali. That was really clear, and I commend you for your PowerPoint skills. I mean, there were lots of amazing statistics there, striking results that I think we need to take home, and we can sort of count them off. One of the ones that I was intrigued by is really that change in dipping over time with transplants, and also obviously the fact that non-dippers is so prevalent. May I ask a mechanistic question to start with before we go to the details of the meta-analysis, and ask you to speculate on why you think dipping returns after transplantation, why it takes so long? What might be the factors? Is it returns of vascular function, improvements in vascular stiffness, or do you think it's something different?
You see, I cannot give you, let's say, a precise quantitative answer, but I can tell you that over time in transplant patients, arterial rigidity improves. But to me, the most important factor is the control of volume excess. As you know, dialysis patients are volume expanded in the 50 to 80% of cases. And volume expansion determines edema of the glottis, edema of the hypopharynx, and this triggers sleep apnea. And sleep apnea is a very strong risk factor for alteration in circadian profile. After transplantation with restored diuresis, the edema, including the edema of the hypopharynx, gradually resolves. And to me, this is probably the most important factors for the progressive improvement of non-dipping.
So going to that question, if you were treating kidney transplant patients, when will you recommend to perform the ambulatory blood pressure measurement? What should be the good moment? Because if early we are having these findings that are different than later on, which moment do you recommend?
You mean the application of ambulatory monitoring?
Yes.
Okay.
I mean that.
I think that we should start applying ambulatory monitoring when the patient are stabilized. Let's say after the first month, during the first month where the risk for rejection and early complication is high. I think that the information you can get 24-hour ambulatory monitoring is very modest. The first measurement can be also delayed up to the 6th month, but in any case, during the first year, I would recommend measuring 24-hour ambulatory monitoring. Maria, I have to add that this is very controversial because many American colleagues don't agree that ambulatory monitoring should be applied in transplantation. To me, this is an odd position because if British doctors apply 24-hour ambulatory monitoring in the general population, why not applying the same metric also in high-risk patients for alteration in circadian profile?
Carmine, my question is, the incidence of uncontrolled hypertension in kidney transplant patients, according to your results, 56%. And we follow these patients. How could you explain this? This is very huge numbers. So nephrologists could not be able to control hypertension.
You mean acute hypertension?
No, cumulative incidence of uncontrolled hypertension according to your results.
Okay.
It's too high, right? So how could you explain this?
Yeah, okay. I must say that the proportion of patients with uncontrolled hypertension is high and remains high. But in the papers that I showed, in many of them, it was probably too high also because these papers were not fresh, were old papers 20 or 20 years ago. The problem is that, to be frank, are doctors. The problem are doctors because transplant physicians in general pay the maximum attention to immunosuppression, but not rarely they overlook the risk associated with hypertension. A couple of years ago, I informally interviewed colleagues of mine in Italy, in the north, in the center, and the south, to ask if they apply 24-hour ambulatory monitoring. And they said, no, we don't need ambulatory monitoring. And I insisted, but in how many patients of your clinic is hypertension controlled? And most of them replied, I don't know.
I see. The second question, I wonder your clinical practice. We have many patients and we use ABPM. Some of them has nocturnal hypertension, some of them has non-dipping hypertension or reverse dipping pattern. So is your clinical approach is different in this kind of patients or same? And the second part of this question is, what is your opinion about chronotherapy in this kind of patients?
Yeah, this is a good, very topical question, Mehmet. Chronological therapy, it's a possibility, but we don't have a specific paper in transplant patients. No single paper tested chronological therapy in transplant patients. But in the general hypertensive population, there are several. And a few years ago, a meta-analysis was published about the application of drugs in the late evening to prevent the non-dipping phenomenon. And the efficacy, I must say, of application of the drug in the late evening was less than expected, much less than expected. Normally, the non-dipping associated with flat hypertension during night. The use of a drug in late afternoon lowered the systolic blood pressure of a modest amount in this meta-analysis, 3 or 4 millimeters of mercury. But generally speaking, I would recommend taking the drug in late evening, because 3 or 4 millimeters of mercury is always important in epidemiological terms.
Do you follow more closely in patients with nocturnal hypertension, or your recommendations are same?
Could you repeat, please?
In patients with nocturnal hypertension, do you follow these patients more closely or same with other patients?
You see, white coat hypertension.
Nocturnal hypertension, I mean.
What?
In a patient with nocturnal hypertension, the risk of cardiovascular event significantly increases. So is your recommendations same with patients without nocturnal hypertension, or do you recommend other things?
What matters is the burden imposed by nocturnal hypertension, because the presence of nocturnal hypertension, even in the absence of high blood pressure in the morning hour, raises 24-hour ambulatory monitoring, the average value. And this, of course, increases the burden of blood pressure in the cardiovascular system. When we use drug independently if the drug is efficacious on the nocturnal dip, we lower 24-hour ambulatory blood pressure. And therefore, there is a huge benefit.
Okay. So my last question, if we could not be able to use ABPM, do you prefer home monitoring or office measurement? What is your opinion?
On monitoring. In the meta-analysis, we touched upon on monitoring. On monitoring, even though the information was not so large about the agreement between home monitoring and 24-hour ambulatory monitoring, home blood pressure had a better association with ambulatory monitoring, which is the golden standard, of course.
There are some questions from audience, and Will may ask.
Okay, so can we stick with home monitoring for a while, because I favor home monitoring as well, but not based on data, based on the fact that it really helps me motivate patients. I mean, I've seen education attainment associated with outcomes in CKD, and a lot of that association is mediated by conventional risk factors like blood pressure. So I use home blood pressure monitoring because it gets people's attention on their blood pressure, makes them bring in readings. That helps me with it. I think it helps me with adherence without evidence. But one of the things I don't do is give them specific instructions on what time of day they should do their monitoring. I say do it 2 or 3 times a week and write it in a diary. But it seems to be that daytime and nocturnal hypertension might be something we can still try and ascertain even from a home reading, even though it's not validated. So do you give specific advice to your patients when you get them to do home measurements to try and get a range of readings across the times of day? And do you particularly want to see nighttime readings, for example?
I used to do that 3 times in the morning and 3 times at night for 1 week, only 1 week. If it's the week before my outpatient consult, is better, but if they are traveling 2 or 3 weeks before, I don't mind. They have to live a good life. But I used to do 3 times at morning, 3 times at night, and I used to say the same things that are now recommended in the guidelines. So no coffee 1 hour before, no smoking 1 hour before, go to the toilet before taking the blood pressure, do not speak whether you are taking your blood pressure, the correct position. So I used to explain all of that.
Okay, on monitoring, of course, is a step forward from office blood pressure. And on monitoring has the merit of empowering the patients, because she has his blood pressure in his hand. He should control, he has the instrument to control it. The problem with on blood pressure is that it does not capture the fall overnight, which is fundamental for estimating correctly the burden of blood pressure. But in this respect, I must say that clinical research is making important step forward. Now, very cheap instrument that measure 24-hour ambulatory monitoring and are directly operated by the patients are being experimented. Instruments whereby the patient himself, every week, every 2 weeks, it depends on the prescription of the doctor, takes the instrument and easily measure the blood pressure 20 or even more times a day. I think that these instruments are the future because they are very cheap. You know how much it costs standard high-level ambulatory blood pressure monitor. It costs about 1,000 euro now. A cheap instrument is down to 300 euros. So we nephrologists like to have in our unit for example, the BCM, the BIA, which to me gives, in terms of clinical information, less information than 24-hour ambulatory monitoring for dealing with cardiovascular risk.
Coming back to the, may I add something? Coming back to the nocturnal hypertension, I think that is extremely important, also because it is associated to sleep apnea. And patients with sleep apnea are at higher risk for stroke, for instance. So nocturnal hypertension is extremely important also to recognize people at a higher risk, transplant patients with a higher risk. And on the other hand, today, there are very cheap devices to correct sleep apnea. And they are not, they are patients tolerate this kind of a small device to correct sleep apnea. So it's extremely important to make diagnosis of sleep apnea. One indirect sign is nocturnal hypertension. It is associated with sleep apnea.
Sorry, do you ask any question about sleep apnea during clinical practice? How do you assess, evaluate? Do you ask snoring, or do you use any assessment, or do you recommend something?
No, first of all, we ask if the patient snores, because this is very important. It's very often associated to sleep apnea. And if snoring is important, usually we ask when the patients are in couple with the partner, because the partner knows very well if the patient snores. And if we are particularly concerned about the symptom, we make the polysomnography.
In this respect, it's worth reminding that nocturnal hypertension can be corrected by paying attention to volume. The first thing is to control volume and to relieve the hypopharyngeal edema. That's the first things to do. Secondly, we can consider also other treatments. Studying sleep apnea now, it's more easy than in the past. Because in the past, patients had to be studied in the sleep laboratory, which is very costly. One night in the sleep laboratory can cost up to 3,000 euro, which is a huge cost. Now there are very simple instruments, well validated, that allow home self-monitoring of oxygen tension, and also the monitoring of the movement of the thorax, and make the diagnosis of sleep apnea very cheaply.
So, Carmine, Zoccali, can I stick with this issue of volume? You caught my attention with a couple of things. I thought we could, in a second, talk about, which choice of antihypertensive you use for non-dippers, and I think that's been a subject of quite a lot of study, and whether or not that data is consistent. But one of the things you mentioned was BCM or BIA, bioimpedance spectroscopy. And you said that you felt that the blood pressure gave you more information than bioimpedance. Have people done in the transplant population correlation studies between body composition measuring and blood pressure? I'm obviously very aware of your work and others' work in dialysis populations, where it's regularly measured. We haven't seen much in CKD populations. I mean, we're interested in ourselves, but have they done it in the transplant population and correlated it with different blood pressure measures?
You mean how can we, let's say, transfer to the transplant population what we know and what we do in the CKD population?
No, I'm talking about wheeling the body composition monitor machine from the dialysis unit into the transplant clinic. Has anyone done that at scale?
The number of studies with the BCM or BIA machines in transplant patients is limited. And these studies can help interpreting blood pressure in transplant patients. If available and when available, these instruments, of course, are useful for monitoring progressive dehydration. But to my knowledge, there is no proper study, because I would like to see a study where a simpler indicator is applied, like, let's say, body weight.
Yeah, okay. And the other thing is that when we, even in early transplantation, when we do identify hypertension, and we're obviously missing it half the time, we often jump to the calcium channel blocker. But that doesn't fit with the hypothesis of volume overload. We are often concerned about use of diuretics, use of RAS blockers even. And I wonder whether the data fits with your hypotheses and whether or not we should be thinking of using these agents more commonly. And I know you've been thinking about cost effectiveness of different agents. I don't know if Francesca wanted to answer this question.
You see, I can tell you that in a previous meta-analysis we did, we look at the drugs that were applied for treating hypertension in transplantation, and I noted that the use of diuretics was less than needed. We should not forget that transplant patients are CKD patients because they have chronic kidney disease. And chronic kidney disease, diuretic treatment and low salt diet is fundamental.
Yeah. Yes, the low salt diet is an important tool in our hands, just to try to convince people at least not to overuse salt, because I'm sure that when we prescribe every drug or the patients does half of what we prescribe. So hammering them about low salt, or at least lowering salt in their diet is very important. Also for, as Carmine said, for volume overload and sleep apnea, because volume overload is one of the first causes of sleep apnea. Another very important problem in renal transplant patients, cardiovascular problem, is obesity, and obesity goes together with hypertension. So I think that the cardiovascular item in renal transplant patients is really a neglected area, because we think maybe too much about immunosuppression and everything, but we don't, maybe we overlook that the patient becomes extremely obese in 2-3 years after transplantation. So I think that we have a lot of work to do.
Problem is that, Francesca, while immunosuppression is nicely handled by transplant physician, changing lifestyles is tantalizing. Will is an epidemiologist. He knows this very well. I recently reviewed the adherence to the low sodium diet in CKD. I found 11 studies. In these 11 studies, the longer the period of exposure to low sodium, the less adherence to the low sodium. After 6 months, there was absolutely no adherence to the low sodium diet. And this was true in CKD patients, but I'm sure that in transplant patients it's the same.
Yeah, I agree. But at least we have to insist on it.
Certainly, certainly.
Clinical inertia is the worst attitude of that a clinician could have.
In this respect, we did our best to improve adherence to the low salt diet.
Yes, yes.
We have already tested an instrument that allows patients self-measurement of urine sodium. The system was well validated. We published the paper in Clinical Chemistry. But when we did the trial, the instrument was used by the patients, but sodium excretion remained high.
So I was looking at the questions from the audience. I think during the course of this, we've answered a lot of them about when to do home blood pressure measuring and a bit about the mechanisms, but one has come up and asked very specifically, when would you use an ACE inhibitor or an angiotensin receptor blocker in a transplant? Maybe Mehmet, maybe have you got an opinion on that from Istanbul? When do you use a RAS blocker?
Francesca and Carmine has excellent studies about this.
Yes.
And they showed that calcium channel blockers should be first-line agent. And they showed the superiority to renin-angiotensin system blockers in kidney transplant patients. In my clinical practice, I generally use also renin-angiotensin system blockers after 3 months. If the patient's kidney functions are stable, and after doing renal kidney Doppler ultrasound. If there is no obstruction, I prefer to use these kind of AC inhibitors or ARBs because of it has many beneficial effects on cardiovascular system, and also it has many beneficial effect on kidney also. That's why I prefer to use these kind of agents after 3 months. Maybe Francesca or Carmine may add something also, but with calcium channel blockers.
Yes, in the meta-analysis, the previous meta-analysis we did, calcium channel blockers prevented graft loss, while paradoxically, ACE inhibitors and angiotensin II receptors antagonists did not. But this was mainly due to the low power of the meta-analysis, because in transplant patients, the number of studies of antihypertensive agents is limited as compared to studies done in the general population.
So I'm looking to the future now. I remember before when all of the CKD trials and SGLT2 inhibitors were reported, there was the EMPEREG BP study. I remember it showed modest but clear reductions in blood pressure during the day, and also effects nocturnally, and maintained the circadian pattern of blood pressure. Is anyone using SGLT2 inhibitors in your transplant patients to try and improve blood pressure control, maybe in those that are really resistant or have got particular reverse dipping features? Or is this still something for the trials to be investigating?
To my knowledge, there are no trials in this.
Yes, there are some cases reported, and also a few days ago, new case series published in Clinical Transplantation. They showed that it has some beneficial effect, but the number of the cases is only 17. So we cannot be able to recommend strongly. We need more big trials.
There's been one trial of about 20 patients in both arms, which shows that they only have very modest effects on hemoglobin A1C. But I don't know if they looked at the pattern of effects on blood pressure. But I did see on Twitter the source of all useful information and in early news is that there is plans for large-scale transplant trials. Some funding is there. So I think this is an interesting area because you've got the paradoxical issue with the RAS inhibitors, but also Francesca's point about managing weight control and sodium control, and also the edema of the pharynx.
But we have to keep in mind the infection risk also.
And it's a perfect group for a trial, yet because of there's equipoise about the safety.
Yeah.
So, Mehmet, do you have any final questions for the team?
No, thank you for this excellent question and words again to Carmine and Francesca.
And Francesca, do you have any questions for Professor Zoccali?
I don't have any question for Carmine.
Carmine, did you want to have any final words before I close the e-journal club?
Do you want me to make a conclusion, make a perspective?
Well, I think the things that I always try and take away 3 key facts that I will try and retain and never forget from these e-seminars. And the first one which frightened me was the prevalence of masked hypertension from your study. It's as common as 1 in 4 transplant patients have masked hypertension that we don't know about, because if we're only doing office blood pressure, we miss it. And also the frightening statistic of just over half of the patients are non-dippers. So it's almost like, and although this changes with time, it's almost like it's an epidemic of non-dipping blood pressure. And you recommend doing a diagnostic ambulatory blood pressure measurement to try and identify those. I think one of my last conclusion is, if I don't have an ambulatory blood pressure measurement, I'm going to get my patients to intensively measure their blood pressure. I'm going to have a very low threshold for fearing the existence of non-dipping. Are there any other really important points that I really should take away and that the audience should remember that I've missed?
I would like to add that I recommend 24-hour ambulatory blood pressure monitoring for the diagnosis of hypertension. But of course, all of us are aware that applying ambulatory blood pressure monitoring for following up patients and monitor drug therapy would be very hard, because you would need to reorganize your clinics. And this is simply logistically not feasible. So for the diagnosis of hypertension, ambulatory monitoring. For monitoring therapy and adjusting therapy in everyday life in the clinic, we can rest on standardized blood pressure and study at baseline the relationship between standardized measurements and 24-hour ambulatory monitoring. Being aware that as the times passes over time, the risk of nocturnal hypertension in transplant patients diminishes, and therefore the systematic application of the 24-hour ambulatory monitoring may be less stringent. The fundamental issues, initial diagnosis.
Thank you so much, Professor Zoccali, from myself and Maricela. Thank you also to Professors Francesca Mallamaci and Mehmet Kanbay. Thank you so much for your time and always sharing all your knowledge. It's been a sharp reminder for me that the hypertension is so prevalent and appears in lots of different guises. It tries and hide itself, but it's within our power to modify and could have a major impact on our transplant patients. Please do go to CKJ website and read the open access research paper and Professor Kanbay's accompanying editorial. There is also a substantial number of NDT meta-analyses that are highlighted in the presentation, and there are more besides on NDT looking at specifically calcium channel blockers, and I can see more questions about calcium channel blockers in the chat. For those in the audience, we appreciate you staying on just 1 minute more. Please answer the survey. It's short and the feedback helps us keep these e-seminars. And please put the last Thursday of the month in your diary to join more ERA journal clubs. Next month, I have an advert. It's Jennifer Lees and Kate Stevens We're planning to discuss predictive models, and it links directly to this because they're talking about lifestyle factors, as we've discussed today, but this is from a cohort of patients, 440,000 Taiwanese adults in their amazing National Health Service system with registry data and health linkage. And it's looked at the kidney risk failure equation and how lifestyle factors may improve its predictability for starting kidney replacement therapy. Very interesting data. I'll certainly be registering from the ERA website. But for now, it's goodbye from Maria and myself and the panel.
Bye-bye.